Welcome to this presentation. My name is Arne Kirkhorn Rødvik. I'm a medical physicist at Oslo University Hospital, Rikshospitalet. This picture shows the part of the human body in real size, which will be the object of this presentation, the cochlea. So first I will talk about what is a cochlear implant more in detail. We see on the picture that the sound is picked up by the microphone and converted into an electric signal, which is then transferred to the speech processor. In the speech processor, this signal is coded into a particular pattern of electronic pulses, which are sent to the coil and thereafter to the implant by means of radio waves. These electric pulses are sent through the electrodes of the implant and released at certain points along the stretch of the cochlea. The electric pulses are picked up by the hearing nerve and sent to the brain. The brain then interprets these signals as sound. On this slide are the CIs that we currently use at Oslo University Hospital from the three manufacturers Advanced Bionics, Medel and Cochlear. In Norway, all CI surgery and programming of children is performed at Oslo University Hospital, Rikshospitalet. Both Oslo University Hospital and two other hospitals in Norway perform surgery on adults. And both Oslo University Hospital and 5 other hospitals perform CI programming on adults. The cochlear implant team at Oslo University Hospital, you can see on the pictures, are a lot of people. There are 5 surgeons at the moment, 8 audiologists or audiograph in Norwegian, 7 medical physicists, 5 speech and language therapists, and patient coordinators. This figure shows the basic steps from referral of a CI candidate through his or her habilitation period. And this is a chronological flow chart, but of course we deviate from this chart in some cases. For example, children are prioritized, or adults with meningitis or other time-critical conditions are prioritized. So in this part of the lecture, I will present what happens before a CI is provided to the patient. So in general, who are candidates for cochlear implants? Babies and toddlers born with a profound hearing loss, children and adults who have previously had hearing but have acquired a substantial hearing loss progressively or suddenly, children and adults with other diagnoses, for example auditory neuropathy or tinnitus, and adults that satisfy the national guidelines, which are hearing threshold above 75 decibel hearing level between 2 and 4,000 Hz, or a hearing threshold above 60 decibels at 1,000 Hz. And in addition, less than 50% score on speech perception tests on both ears and minimal benefit from hearing aids. And who are not candidates? Persons whose hearing is too good according to national criteria, those whose improved benefit from a CI compared to a hearing aid is unlikely, those who are congenitally profoundly deaf and referred too late, which can be older than 6 years, and those with anatomical limitations, which can be missing or abnormal cochlea, ossified cochlea, missing or thin hearing nerve, or auditory deprivation due to long-term hearing loss. And finally, persons not motivated should not undergo a cochlear implant surgery. I will now go through the different parts of the hearing assessment of CI candidates at the hospital. The assessment starts with the received referral from an external ENT doctor. MR and CT images are sometimes already performed elsewhere, otherwise it has to be performed later. In our multidisciplinary CI team, several objective and subjective hearing tests are performed, among which are the important pure tone audiometry and different speech perception tests. The results of the assessment are discussed in a meeting with persons from all professional disciplines present. Thereafter, in a consultation between the patient and his/her relatives, guardians, an ENT doctor, and a speech and language therapist will inform the patient either that he or she is an eligible CI candidate or explain why CIs will not benefit the patient. The former will be offered surgery for cochlear implantation. So I will now sum up the evaluation process of CI candidacy. Eligible patients are offered uni and bilateral CIs simultaneously or sequentially, depending on etiology. One-sided deaf are in some cases, for example, invalidizing tinnitus, also offered a CI. To be offered a CI, it must be likely that the patient's hearing will improve. So this is very important. A person who has never previously heard anything in his/her life will not develop hearing if cochlear implanted as an adult. I will now give an overview of the cochlear implantation process. The pictures show the implants from the 3 manufacturers in use at the hospital, which are Medel, Cochlear, and Advanced Bionics. The duration of the surgery is 1 to 3 hours for a unilateral CI. Technical tests of the implants are performed during surgery. Many patients are discharged from the hospital already in the evening after surgery. So it's not a very dramatic operation. So here are some pictures from the surgery. As you see, the ear is clearly marked before surgery starts. During surgery, a basin is drilled in the mastoid bone in which the implant will be placed, and the implant electrode is inserted into the cochlea through the round window. After surgery, the incision is stitched up and plastered with steri-strips. In order to preserve the residual hearing on the patient and to preserve structures in the cochlea, soft surgery is often employed. But hearing preservation cannot be guaranteed 100%. Choice of CI electrode is important in that respect. Some electrodes preserve the hearing better than other electrodes. The potential complications and side effects are fortunately very rare. Such complication can be a negative reaction to anesthesia. It can be loss of residual hearing, meningitis, partial damage of facial nerve and taste nerve, dizziness, elicitation of tinnitus, and infections. The CT image shows a bilaterally implanted child. Post-operative CT is only performed when the objective measurements during surgery indicate to do so. The final part of this presentation will be about what happens after CI surgery. The CI is activated 4 to 6 weeks after surgery. At our hospital, there is a 3-day program for the CI activation. The patients are coming to the hospital 3 days in a row. The patient should bring a relative, guardian, or friend to not be alone when he or she has the CI activated. There are 2 programming sessions each day. The medical physicist measures hearing thresholds and uncomfortable levels with CI and equalizes the loudness of the CI electrodes. The volume of the sound is gradually increased during the activation period. Testing of all speech sounds are perceived during the activation, and Link's 6-sound test is always performed. The physicist ensures that no particular sounds are uncomfortably loud. The speech and language therapists check the benefit of the implant and tries to motivate the patient for auditory training. The speech and language therapist always refers the patient to external auditory training. In a CI programming session with children, we often use objective and subjective methods. Eye blinking, smile, discomfort are registered of the child, which guides the programming. It's important to have a good cooperation with the parents of the child to interpret the reactions to the stimuli. Auditory verbal therapy, AVT, is currently offered by Oslo University Hospital. In CI programming with adults, we used mostly subjective methods, as the adults are able to articulate their sound sensations and communicate the wishes. Most cochlear implantees experience a significant increase in speech perception. As you see on the right side, we often use a scale that the adult patient is supposed to assess the loudness of the volume, which is going from very soft to very loud. One day after activation, a speech and language therapist will check the auditory perception status of the adult patient. It will not be possible to check this in detail with a baby or a toddler. All CI users will be offered a referral to an external speech and language therapist. To maximize the perception output of the CIs, auditory training is strongly recommended. Thank you for your attention.